in Society, and it's my pleasure this afternoon to moderate the first set of proceedings. First up is Virginia Bartlett, who Joe introduced earlier during his remarks, so I won't take away from her time and say anything else.
Thank you and good afternoon. Technologically incompetent, so thank Joe once again. I'll go ahead and start while we're getting this set up. Today I'm going to be talking about religion and genetics in the caring professions. As we heard from Larry and Joe, one of the goals of this conference is to explore the concerns of patients and clinicians and clergy in the encounters where religion and genomics interact. In this presentation, I'll talk about the reflections and stories that we have heard from members of the caring professions and sketch out some key themes that emerged from this preliminary research. Thanks to our grant from the Center for the Study of Religion and Culture, the Vanderbilt Working Group conducted focus groups with members from 5 caregiving professions. We heard from the first group, whom I'll call clinicians, and this group includes physicians, nurses, genetics counselors, and then the second group, whom I'll call clergy, includes ministers and hospital chaplains. Each focus group was moderated by a member of the Religion and Genetics Working Group and observed by another member. In focus group conversations, our participants revealed a complex set of attitudes towards the role of religion or spirituality in areas of genetic concern, as well as for health in general. I'm going to describe 4 broad themes that emerged before Dr. Rolanda Johnson will explore one group, the nurses, in depth. Participants in each focus group were given a set of case studies as a springboards for conversation. Again, this is kind of the using stories to elicit stories from people. So we had 4 topics: prenatal diagnosis, genetic testing of children, genetics in cancer, and predictive testing of Huntington's disease. In each focus group, we asked a set of open questions about the ways religion and genetics emerged when dealing with genetics. In which religious concerns emerged when dealing with genetics. And invited participants to consider the case studies or their own experiences in reflecting on their answers. We asked clinicians questions about their personal experiences with religion and health concerns in general, and with genetic concerns in particular. We asked them to tell us whether and how their own religious commitments affected their relationships with patients, and we asked them whether they thought professionals should assess patients' religious or spiritual concerns. Religion is not typically understood as part of the clinical role, so we wanted to hear about their experiences. We asked similar questions of the clergy, but with the aim of learning how genetic or even broader medical concerns impacted their parishioners and their relationships with parishioners. We asked the clergy to tell us about their experiences with genetics and whether their commitments shaped how they dealt with genetic information and events. Some participants focused on the case studies and their responses, and others told stories from their own experiences. Notably, every participant, whether clergy or clinician, had some reflections or stories about religion and genetics to share. The data collected in this first round of focus groups was preliminary and it was broad-stroked, but it has been illuminating. Religion and genetics are often presented as deeply opposed to each other, but we learned how deeply entwined these concerns are in public understandings of genomics, in clinical encounters, and in interpersonal experiences. That said, trying to sort through the mountains of data from these preliminary focus groups, a few things are worth noting. First, we discovered, importantly, how many themes emerged from focus groups. These conversations were passionate and involved, and they reflected the complexity and richness in the experiences of care providers. The second thing to point out is that this is a complicated topic, made more complicated by how important these themes are to our participants. We want to acknowledge that terms such as science and faith, religion, spirituality, and difference are disputed in intersubjective encounters as much as they are in academic journals. Nonetheless, the codes that we used to organize and analyze these themes emerged from the language of our focus group participants. In a similar vein, the particular word choices of our participants affected the coding. So, for example, kind of related to Larry's talk this morning, interviewers were careful to open the conversation to both religion and spirituality. introducing both terms in our questions. But in most groups, by the end of the conversation, participants had defaulted to religion for describing most of their stories and experiences. So religion became a major code, spirituality a somewhat minor code. The final point I wanted to make is, in what Rolanda and I share today, reports of patient beliefs and concerns and needs are simply that. These are reports. These are reports by clergy and clinicians. We haven't yet conducted focus groups with patients and families, so these are secondhand stories and attributions of beliefs, meanings, and desires. But what they show us is how the professionals see the needs and concerns of their patients and their clients and their parishioners. So we'll move on to our codes. In the open coding that generated our master code book, we had over 30 distinct themes emerge that were prominent enough to be used as codes. We're going to look at the 4 most prominent themes in the top tier there, but I want to emphasize some of the others, or show some of the others to emphasize the complexity here. Some codes were limited to specific groups, and some themes were understood differently in different groups. So, for example, Catholicism came up frequently with clinicians, or the idea of journey came up among clergy. We had some codes that came up infrequently. Satan emerged in several conversations with ministers and clergy. The concept of non-Western traditions, stories about non-Western traditions, came up with clinicians. These could be considered outliers, but they seemed important enough in the particular conversations to mark as areas for further research. And one of the things that distinguishes this project and our data is the complexity of this topic in breadth and in depth. These themes are important because there are so many things that matter and because they matter so much to those involved. So again, with the time constraints, I'm going to talk about the first tier, but this was just to show you some of the codes that emerged. So the key themes, in all 12 focus groups, participants raised issues that we coded into 4 areas: difference, religion, resources, and the relation between science and faith. In the definitions that we used to code the data, difference marks comparisons and differences between people, groups, regions, or institutions. Religion marks any reference to religion or descriptions of a person, group, event, or experience as religious. Resources marks references, direct quotations about resources, including using other people or networks for help, publications or reference materials, and professional development programs such as cultural competency training, continuing medical education, and clinical pastoral education. And finally, the science and faith relation marks conversations about the connection, relation, or opposition of medicine and belief, nature and technology, or science and faith. So we'll look at each one of these individually. Beginning with difference, focus group participants identified and acknowledged differences among their professions, as well as regional and institutional differences in addressing religion and genetics. Different groups responded, for example, differently to questions about genetic testing. For many clergy, genetic testing was seen negatively because it was associated with prenatal testing, and prenatal testing was immediately associated with abortion and religious concerns. For many clinicians, genetic testing did not raise religious questions, but was seen as a tool yielding valuable knowledge and information. But these clinicians also told us that their patients, many of their patients, associated genetic testing with prenatal testing and abortion. So in this one example, we see a whole set of differences that emerged among the professions. Participants also talked about differences in religious areas of the country: Catholicism in the Northeast, the Bible Belt, where you all are at the moment. Others talked about the number of different religions they encountered, especially in larger cities. One clinician, for example, talked about the difficulties she faced being a non-Christian in a southern city with a mostly Christian population. She felt uncomfortable when patients asked her to pray with them, which they did on a fairly regular basis. In the alternative, we had another clinician who told us that she takes a moment to herself before to pray before meeting with each family, and that this prayer helps her to focus on the family that she's about to counsel. So the chaplains we spoke with in particular were attentive to differences among people's faith and responses to genetic or health situations. And they noticed in particular the challenge they felt in bridging traditions to help people cope in the hospital setting. Other important differences include those between denominational positions and individual beliefs, as well as recognizing the uniqueness of each family and even members within a family. Finally, others talked about the differences found among Catholic hospitals and in Catholic hospitals and between religious and non-religious institutions. For example, one genetic counselor at a Catholic hospital talked about a nun who was on call to talk to the families. The genetic counselor would often ask the sister to be present from the beginning of a counseling session, especially if they knew that there was an anomaly. The sister herself asked to be called before the clinicians met with the families, in spite of resistance from some staff members. So this story highlights just some of the differences in religiously affiliated hospitals, but also the different views among clinicians about roles, religious involvement, and appropriate care. So in sum, differences affect how clinicians and clergy understand genetic testing and information, and how their beliefs or orientations affect their interactions with patients, clients, and parishioners. Differences in background and setting and beliefs also affect what care providers see as the appropriate relation between religion and genomics. And in our conversations, both clergy and clinicians expressed a wish for additional opportunities to discuss these differences and their own experiences. Religion emerged as another key domain in each focus group. For clinicians, variations emerged in how they perceived the patient's use of religion and religious language. Clinicians reported on the different aspects of religion, such as prayer or church attendance, as mechanisms for coping or support, and language such as God's will or providence as tools for interpreting genetic information. Many clergy members expressed concern that clinicians overemphasized the negative aspects of genetic conditions and overlooked the importance of religion and faith in a patient's interpretation of information. In several groups, clergy members introduced the idea of communal discernment and the need to connect patients to people, preferably people of faith, who had experienced similar situations. For many clergy and their parishioners, religion was a significant way of making meaning in health-related situations, interpreting their experiences as blessings rather than devastations. Clinicians indicated tensions around whether religion in the clinical setting was personal and private or public and disclosed. Some clinicians saw religion as personal and private, and a personal and private part of their lives and their patients' lives, and they did not want to raise religious questions or issues with their patients, and were even hesitant about responding when their patients talked about prayer or faith or religion. Other clinicians embraced religion and religious issues as they provided patient care. They publicly disclosed their own faith and invited patients to do the same. And though many clinicians were open to discussing religion, almost every focus group of clinicians had some negative stories about patients' experiences with religion. We heard about clergy who walked out on patients for not having enough faith, and patients who refused medical testing or treatment as contrary to God's will. So we shared this story in particular to show some of the tensions clinicians encountered with religion. And although these occasions are not typical, they do happen. And their vividness, we imagine, might explain why some clergy find clinicians hostile to religion. This is something else that came up in our conversations. So these attitudes and negative stories are important areas to consider and to keep talking about with clinicians, clergy, and patients. So we can see from these examples that religion is a complex theme, carries multiple meanings and associations. For the clergy, religion can mean one's faith, tradition, or denomination. The community of support, activities like prayer, concerns over what one person called the health, wealth, and prosperity gospel, or another idea was the idea of living this side of the promised land. For clinicians, religion can operate as a coping mechanism for families, an area of private concern, and at times a negative factor in patient care. In both groups of care professionals, however, there was enthusiasm for discussing these interactions and interest in participating in and learning from future studies. And this leads us to our next and third major theme, resources. Conversations about resources followed two trajectories: resources for care providers and resources for patients and parishioners. Care providers talked about the resources they have used and those they would like to have, and they reported the same two types for their patients or congregants: resources they've used, resources they would like to have. There were several areas of overlap between the two main groups. For example, ministers reported using physicians in their congregations as resources for learning about genetic conditions and as an authority for counseling their parishioners. Similarly, healthcare professionals reported using chaplains, such as the genetic counselor who worked with the nun to help counsel patients, or physicians who developed strong working relationships with hospital chaplains. Many of our participants from both focus groups indicated a desire for more education on genetics for non-specialists and reported the desire among their patients and clients, a desire for resources to help make sense of the new and bewildering genetic options and information. Participants talked about difficulties in translating information about genetic testing, options, and diagnosis for laymen, and both clinicians and clergy expressed an interest in clinical pastoral education or continuing medical education courses. Further, many healthcare professionals cited a need for more educational resources on specific religious beliefs. This is again kind of back to the elusiveness in this area, and in particular, people wanted to know about non-Christian traditions and variations within Christian traditions. So on the other hand, some of these healthcare professionals also noted, as we have here already, noted the limitations of relying on these kinds of resources and materials. They explained that in their experiences with families, personal beliefs often carried more weight than denominational or doctrinal positions. So one clinician told a story of a Jehovah's Witness who elected to use blood products after surgery because he felt that God wanted him to live and had given him this opportunity. And according to the clinician, this man felt that his understanding of God was more important, valuable, and relevant than a church rule. So for the clinician, listening to the patient was more important than making assumptions based on denomination or doctrine. So in sum, our participants indicated that resources on religion and genetics are helpful, but recognized first that things change rather quickly in genomics and genetic advances, and that in their experiences they provided the best care to patients and families by focusing on the unique families they encountered. Resources for family and patients. Clinicians told us that the next crucial step to help them would be in providing resources to to patients and families, and that the best way to do that would be to find out directly from those patients and families what resources they want and need. Our subjects reported that patients and parishioners made use of, already had access to religious communities and networks, as well as clinicians in those communities, and that the internet was another readily available resource for patients and parishioners. But clinicians reported that their patients encountered a lot of misinformation from websites regarding the scientific aspects of genetics. Our focus group members also reported that patients and parishioners wanted more accurate and understandable information and wanted the opportunity to discuss their concerns about religion and genetics with knowledgeable people and with people of faith. And this brings us to our final domain, the relation between science and faith. This relation emerged as a contested domain in each of the focus groups, with positions ranging from an either-or conflicting relationship, either science or faith, to a different but complementary relation, or to science and medicine being viewed as a grace or a gift from God. In the first position, the either-or, participants made a sharp and adamant distinction between the goals, practices, and benefits of science and faith. We encountered clinicians who thought that medicine was simply about science, had nothing to do with faith, and that in situations of conflict, science trumped faith. We spoke with clergy who felt that medicine and science were hostile to people of faith, and that the goals of each were sometimes irreconcilable. On the other hand, as could probably be expected, most participants saw a different but complementary relation between science and faith. So clinicians reported that religion helped their patients to respond to and cope with genetic testing and diagnosis. On the other side, many clergy talked about the potential benefits and the potential dangers of genetic testing and future imagined and increasingly possible genetic manipulation. In this slide, we see a distinction between healing and dealing in genetic medicine. Dealing takes on the pejorative of trying to manipulate genetic possibilities, almost a frivolous use of this science, while healing is viewed positively as a more serious and meaningful use of genomics. Those blue eyes keep coming back. There is some tension. And there's a sense in most focus groups with clergy and from some self-professed believing clinicians that medicine can be a ministry or that science and faith can be a gift from God. The participants talked about medicine's valuable role in responding to health problems, but they also identified concerns with the misuse of medical technologies. So, for example, one minister expressed his concern that the goals of medicine and science conflict with a faith position, even while his colleague tried to justify science as co-designing. So some clergy and their parishioners appear to be apprehensive that their beliefs and their faith concerns will be dismissed as medical and genetic technologies become more commonplace. And as this minister said, for a person of faith, medicine can become an imposition. The idea of the imposition of medicine and science brings us to our last example in this relation between science and faith, the utility of religion in a clinical setting. Clinicians described religion or faith as an important support for patients, as a way for care providers to form a rapport with patients, and as a means of encouraging patient compliance with medical advice or treatments. Science and faith are not necessarily opposed because faith is useful to both patients and clinicians. There was less agreement, however, about the desirability of using religion as a tool or a ploy, in the words of one participant, and on what constituted manipulation of patients. For some of our participants, using religious language was a way of meeting patients on their path. And as this nurse asks, why not bring in more people using whatever cues you have to use? So, the why not question provides kind of a nice frame for the theme of science and faith and for our consideration of religion and genomics as a whole. Clergy and parishioners are faced with the question of why or why not when it comes to using genetic testing and information. Are science and faith in conflict? Are genetic tests and perhaps future treatments going to be offered or even imposed by the medical community? On the other hand, clinicians struggle with the why or why not question when it comes to addressing patient religious concerns or using patient language. Is using this language beneficial or manipulative? Is it a way of forming rapport or a form of imposition? One part of our goal was to identify the ways that people have answered these questions, and another is to help clergy and clinicians, and eventually patients and parishioners, continue to raise and address these questions. Before Rolanda talks to you about her analysis of the nursing focus groups, I just want to reiterate one more time the breadth and the complexity that we encountered in our preliminary data. Our research has been fascinating. I've felt so lucky to be able to live in this data for a while, but it is preliminary and it is very broad-stroked. So each of these themes, all four of those tiers that I showed you earlier, can bear further investigation. There's so much there to consider. So we've discovered, in particular, according to the reports of clinicians and clergy, how much these things matter to those clinicians and clergy and to their patients and parishioners and the families they encounter. People want to talk about how religion and genomics are related, and they're enthusiastic about exploring these questions, as are we. So, having gone through all of that and painted a rather broad picture, Dr. Rolanda Johnson is going to talk to you and give a more focused analysis of one of these focus groups. And we'll take questions at the end.
Thank you, Virginia. We'll now hear from Rolanda Johnson.
Good afternoon. Virginia has already presented a broad overview of the data from some research that we've discussed across or conducted across disciplines. And now my task is to focus a little bit more specifically on the nurses' perceptions of genetics, religion, and health. Now, many of you may be asking, why nursing? Well, if you consider the number of nurses in healthcare delivery systems throughout the country, then you will see, or maybe you can better understand why we're focusing on nurses. Consider that there are over 2.9 million registered nurses that provide health care on a daily basis, as compared to approximately 800,000 physicians and surgeons, 77,000 occupational therapists, and even 182,000 physical therapists. You should come to the conclusion that nurses dominate the healthcare delivery systems. Nurses also provide the majority of personal contact to patients who find themselves coming into healthcare facilities, whether inpatient or outpatient, throughout the United States. And so it's very important that we look a little closer at this particular group to see what are their perceptions of genetics, religion, and health. The purpose of this qualitative study was to, one, explore the nursing perspectives of patients' feelings towards genetics, religion, and health, and two, to explore the nurses' experiences from a personal standpoint as it relates to genetics, religion, and health care, the care that they actually provide. The participants themselves, two focus groups were held, lasting anywhere from an hour and a half to 2 hours. We ended up with a sample of 8 registered nurses, with the majority being advanced practice nurses, meaning that they had master's degrees in designated specialties. The age range was from 31 to 60 years of age, with a mean age of 48. And that average age mirrors what we tend to see with the registered nurse population in healthcare, being somewhere between 43 to 45 years of age. Years of experience, the average was 22 years. You see that gender-wise, the sample was composed primarily of females, which I don't think anyone would argue that nursing is primarily a female-dominated profession. With, on average, in everyday practice, we see maybe 5% of care being provided by males. The nursing specialties that were represented were adult health, community health, pediatric and palliative care, cardiovascular care, and then family nurse practitioners. Virginia has already given you a broad sweep of how we initially started looking at the data. We started looking at examining codes, doing or conducting line-by-line coding, and we came up with initial categories. If you quickly look at this slide, you will see that a lot of these categories that were noted among the nursing sample or the nursing population were very similar to the ones that we saw from other disciplines, whether it was ministers or genetic counselors or whatever. We see very similar categories or very similar data or information being explained by nurses. So let's look quickly or for a few moments at the findings. It was interesting that when I started looking at the data, and then when we as a team started reviewing some of the transcripts, the data itself could be broken down into 2 broad categories. One was the nurse's perspective of how their patients were feeling. The other was their own personal feelings or their own personal perceptions as it may relate to their experiences with genetics, religion, and health. And so this is how the themes will be presented. The nurse's perspective of their patients' feelings, their own experiences, And then as a sub level, things related to genetics and religion, and then things perhaps that are related to genetics and then health. One of the themes that nurses perceived about their patients' feelings dealt with corruption of God's creation. And I think from the dialogue before lunch, you can, to me, this quote sort of supports some of the philosophical and theological debates that we have been a part of this morning. Here, there's a young lady, in this case, the nurse recants, whose family had a congenital dyslipidemia disorder. We won't say disease, we'll say a disorder or a syndrome. And although many family members had been diagnosed with this particular problem, this young lady says that she corrupted God's creation by her lifestyle. What did she do according to her? Although she knew she had, quote unquote, high blood fats, living on McDonald's and pizza corrupted the situation that was dealt to her by God. And so the main points, or I guess the main lines that I would say from the quotes are highlighted in yellow. So the nurse says, so the building blocks of God's creations are corrupted by nature of this world and things that happen within this world. It was something that I corrupted the situation by what I did in this world. And keep in mind, this is the nurse's perceptions of her patient's feeling. Similar to this, a nurse recanted a story about a family with familial cardiomyopathy. And this resulted in a theme of not blaming God. Although several family members had been diagnosed and even died from this cardiomyopathy, the nurse never perceived on her part that the family or this young lady blamed God for what happened. She recanted, but there was never any sense of guilt or blaming that I got from these patients. They don't have a chip on their shoulder about God has done this to me. Another one, which is a very interesting, from a very interesting story, the theme developed was making sense of a tragedy. And here a pediatric palliative care nurse practitioner told a story of a 9-year-old young man from Ghana, Africa, who needed extensive surgery, and without consenting or allowing the surgeons to prepare for the potential of blood products, and I guess you would say a disconnect or a conflict arose. The family was Jehovah's Witness, and so the family's main concern was that if their child was allowed to receive blood products, that their child would no longer be allowed to live under the same roof that they lived under. Furthermore, they would be excommunicated from the church. And then, so what does this mean in the life of a 9-year-old? So this caused a lot of conflict with the nursing staff as well as the team that was providing care for this gentleman or this young boy. And so they went to a local clergy. They called the local religious leader in, hopefully to shed some light on the situation and to provide guidance. Well, according to this nurse, when this church leader came in, he agreed with the family. And then they were stuck with, so what do we do now? There was discussion of whether or not they could take legal action because this young man was from another country. But ultimately, after much discussion, the healthcare team decided to support the family. And so from this nurse's perspective, she says, regardless of the origin of the problem, if it's genetic related, if it's an acquired issue, making sense of that, making sense of the tragedy is hard to do. And sometimes, at least in my population, I would guess, that assigning things divine attribution is really the only way to make peace with the situation. And so in this nurse's mind, assigning importance or assigning these things to some type of divine intervention or mediation was a way to let the family or allow the family to find peace with the situation. And in case you're wondering, this young man did die a few months after leaving the institution. The life could have been prolonged. However, that was a choice the family made. Now, let's look at some themes as it relates specifically to genetics. And we're looking at primarily two major themes. Keeping in mind, we're still looking at the nurse's perceptions of patients' feelings. And these two themes more or less highlight, in my mind, how nurses perceive patients deal with the types of interactions or the types of conflicts that we've discussed earlier. The first thing is coping with realities of illness. So the issue of coping comes to the forefront, and this one in particular is dealing with kids. And here the nurse highlights avoidance coping versus approach coping. Avoidance coping is basically just ignoring that something exists. And approach coping means you look at the situation, in my mind, you look at the hand that you've been dealt, and you try to decide, what do I do about it? And this nurse talks about making meaning out of having the syndrome that I have. Very closely related to coping is hoping. And from three different individuals, we see three different statements as it relates to hoping. And so this theme, hoping, is dynamic, that it's not stagnant, that it fluctuates. One participant says, hoping gives a different perspective. Another, there's different colors, it has different flavors, it has different styles. It evolves, it's fluid. And I think if you think about the conversations that have occurred earlier, you can sort of see the notion of hope as well as cope and how it can change from individual to individual, but then it can also change depending on the stage of illness or where the family or the patient finds themselves. And then finally, let's look at a few themes as it relates to nursing experiences themselves. One nurse talked about how acknowledging different values helped her to cope or helped her to deal with the many different situations that she sees. By acknowledging different beliefs and values of others, then there's a less, urge to force others to agree with staff or healthcare providers. It also, in my mind, helps to find a place that's more comfortable with dealing with internal versus an external conflict. And so the nurse says, I think it's acknowledging their values and their beliefs and understanding, and there was not a place where they could compromise their own, and it was their decision to make. And sometimes in healthcare, that's what we end up having to do. We serve as patient advocates, as nurses, and really it is the clients that we serve that ultimately have to make the decision once we give them the information that is needed or that they request for. The second theme, based on nursing experience, is integration of God from a personal perspective. And here a nurse actually used cope. And so in this subject's mind, she says that it's integrated, that God is a part of who I am. So there's God that's an internal component of this particular nurse. And what's going on with me on some level, you know, and it's different from one patient to another, but it's also, I think, affects how they cope. And so there's a notion of how this individual remains stable or balanced by having God as a part of the personal self. And then, similar to Virginia, resources. Nurses always have helpful ideas of how we can make things better. One is increased changes in the nursing curriculum. Yes, genetics has, for many, many, many decades, have been a part of nursing curriculums, but what is the breadth of that component? And so, over and over again, the nurses themselves said that we need to increase the amount of the genetics component as it relates to nursing curriculums. Once an individual graduates from nursing school, several of the nurses were quick to say that continuing education needs to occur as it relates to religion, genetics, and health or health care. That once you obtain basic knowledge, and we see that as new technologies or new genomic interventions or have been noted or unveiled. Another one was increased pastoral initiated visits. One nurse recanted how oftentimes patients would, when she would say, would you like to see a clergyman? Would you like to see the hospital chaplain? Patients would say, no, don't bother them, they're too busy. But if the same individuals would come on their own and go to the room, then they would engage in dialogue with whatever clergyman or whatever religious person it is. So the nurses in the population felt like increased pastoral initiated visits was crucial. And then finally, increased multidisciplinary collaboration across the various disciplines as it relates to genetics, religion, and health. So, what can we draw from both of the presentations, the one on nursing and the one that Virginia has presented previously? One, just based on the dialogue even beginning last night, we see that this is a very complex field, very complex issues, very complex data. But what it is doing is bringing challenges that for so long that we have failed to discuss to the forefront. Secondly, we see the need for continued discussions across disciplines. Depending upon the discipline, the view that we look at religion, genetics, and health will be very different. For example, nurses tend to be characterized as being more caring, more nurturing. And so when we look at the lens that some nurses may look at these broad areas or these phenomena, we may see that notion of caring or nurturing coming to the forefront. Along with that, nurses need to begin to adapt what we have been taught in previous years to include genomics. Not only is it now, we've always talked about health promotion and health prevention, but we need to look at the interactions between all of the phenomena that we have already begun to discuss. Another, I guess, conclusion would be examining the patient from a holistic approach, examining the interactions of self, the environment, and genotypes, if you will. And then finally, Virginia talked about differences, religion, resources, and science and faith serving as signposts. That for the patient population, one nurse very poignantly talked about, despite differences that we may have, whether they're theological views, maybe there are treatment choices that we may use differently, that we must always embrace the desires of our patients, their beliefs, and their choices, because after all, that is why we're here. We're here for the patients that we serve as we provide a high-quality care as we move forward in this genomic era. Thank you.
So I'm going to invite Rolanda and Virginia to sit at the table with the microphones. We have approximately 15 minutes for questions. I'll invite you to come back up.
Okay, we'll stand here.
Are there particular situations that cause clinicians serious difficulty? That you can recall from your focus groups? Are there particular types of situations that are particularly troubling for genetic counselors or other health professionals, nurses?
I'll go ahead and start with across the board, a major concern for genetics counselors and for physicians and nurses was issues of prenatal testing, prenatal diagnosis, questions of abortion. Because these raised deeply personal and religious questions and anxieties for their patients, which then raised the same questions and anxieties for the clinicians. So that was a major one. Huntington's disease, I just blanked on the word. That case study that we provided them elicited a tremendous response from clinicians in particular.
What was the nature of that response, though, as distinct from the nature of the response to prenatal?
That's a great question. The clinicians that we spoke to about, in regards to Huntington's disease, I guess the best way to describe that is a certain sense of helplessness. There is not much that they can do in to treat that, to do anything about it. So both the patient and the clinician are stuck in the same kind of anxiety and the same kind of uncertainty and the same kind of devastation. So that's actually one as well that our case study for that elicited a tremendous response from clergy, because in the case study, Jeff was the name of the individual in the case study, and he had found out, he had watched his mother go through Huntington's, and he was trying to decide whether or not to get tested, and was afraid that if he did have Huntington's disease, he would consider suicide rather than suicide. So suicide was especially for the clergy, was the hot topic in that one. More so than the actual testing was, and the anxiety produced by the testing were the concerns for the clinicians, if that helps.
So I would have predicted, I didn't even think of the suffering issue. I guess I would have predicted, and maybe my bias will be evident, but that there might have been greater comfort feeling compassion in the HD context than
the prenatal?
Than the prenatal context. Is there a sort of discomfort or unwillingness to go to the issue of compassion about
that's
suffering?
That's not something that that compassion didn't come up in particular, but I will certainly look back into the data for that. That's a great question. Did you have anything with nursing?
I was going to say, as it relates to nursing, because the backgrounds of the nurses were so varied, if I had to maybe select one area that caused a lot of conflict or discomfort, it would probably be the conflict as it relates to their own personal religious views versus that of their patients, and then how the patient's personal religious views may dominate what they decide is the best plan of care or best plan of treatment that they choose. Similar to Larry with the Mount Moriah sign, but because some instances, some individuals say that was a sign from God, but some expressed how dominating doctrine can be when making health decisions, when actually there are some better health choices that can be made with better outcomes. And so that caused, I think, a sense of tension, a sense of conflict. There was even one nurse who did speak of interacting with someone who said that he worshiped Satan. And that caused the nurse to shut completely down. They really couldn't deal with that. And it was a male nurse, and he was like, "I'm just sorry. I was just very professional, but that was to my limit." So that's what I would say perhaps caused the most conflict. Yeah.
We have been talking, I think, primarily about conditions that are diagnosed or impacted at birth or shortly thereafter, the Tay-Sachs and the beta disease. But Huntington's disease typically does not come into play until you're in your late 30s and possibly 40s. I have a very personal relationship to this. My son-in-law watched his mother die from Huntington's disease. He died at 28 in an accident, not knowing and not wanting to know whether or not he carried that gene. His mother's sister, his aunt, is still living but is in the final stages of Huntington's disease right now. My grandson, we are at a stage right now. My daughter became pregnant knowing that her child's family had a disease but had no concept of what Huntington's disease was, let alone the likelihood that her child would have it, or even that it is, once it is a part of your system, that it's not treatable, that it's not like heart disease, it's not like cancer, even terminal cancer. It rapidly creates those problems. What I'm asking here is, we've talked about suffering on a religious aspect, but the suffering in not knowing, the question of ignorance as a care professional, do you have to recognize that you don't have to tell them? Just because the test will identify it, we can't make them take that test if they don't want to fail. Maybe in their case, ignorance is bliss. I have a feeling my daughter will never test my grandson. And can you say that we do have to respect that suffering from knowing inevitably I will have that, even leave out the issue of suicide?
Well, I think from a nursing perspective, that's what healthcare is all about, being respectful of the rights and the decisions of others. I think what will through this discourse or dialogue, we're seeing that sometimes, although we know that it is a patient's right not to know or to refuse treatment, we're all human beings, and that does not stop us from feeling that sense of conflict, that sense of why won't, like your daughter, why won't your daughter have this test? But sometimes we just have to find our own, I guess I would say, professional peace in the situation, that we have indeed helped the individual get to the point where they wanted to be and gain the knowledge that they wanted to have. And then we can start implementing a care or providing the information that they need or that they desire. But I agree, you can't force anything on anyone.
Or even as a parent or parent-in-law,
Right.
to step back and say, it's your choice.
Right.
When I want to know for my grandson's sake,
Mm-hmm.
the relief that he doesn't have it, because if I'm correct, it's a 50-50, totally down the line.
Mm-hmm.
If one of your parents has it, it's still only 50-50 you'll get it. Doesn't matter if one parent doesn't have anything.
Mm-hmm.
I think that's true, and I would just reiterate that, or say one of the more minor themes that came up, and another distinction between the clergy groups and the clinician groups, and of course there was bleeding over and overlap between the two, but the question of information and gaining information and providing information was of much greater concern to the clinicians with whom we spoke than it was to the clergy, although many of the clergy, again, talking about science and medicine as types of ministry, or as gift from God was the language. Information and the use of it played into that as well. So.
I was just going to say very quickly that the history with Huntington. So in answer to your question, I mean, the history with Huntington's disease is, even though the direct genetic test has now been available for 15 years, the uptake is less than 5%. And so, one of the big issues that you're identifying is the value of knowledge per se, and that's highly contested. And one of the things that I'll just set up for you to think about as a way to think about that is that, by and large, we think in regard to genetics, and indeed with regard to healthcare in general, is that people only have to know whatever they want to know. And so they can have the genetic test they want, or they can get the chest x-rays they want, or they can get whatever it is they want. At the same time, there is a fair amount of pressure in the newborn screening area to force people to have knowledge because it's mandatory. And so the issue there, so I just want to identify that as an issue. Yeah, well, I think, and that's really the issue here. So I'm not at all, I mean, I would be amazed that if your daughter is actually being pressured to get HD testing for her son. I mean, that is not characteristic of that. Well, okay, that's a different issue. Families are all interesting. Families are families. But there really is an interesting question there about just the value of knowledge for its own sake, and how that plays out. So I just wanted to identify that. But the data are overwhelming that most people at risk for HD aren't tested, and before the gene was identified, 85 to 90% of those at risk said they would be tested. So when confronted with the reality of knowing which way the sword of Damocles is going to go, they say no.
I'd like to follow up on that. It seems to me that Huntington's is an eliminable disease if we did get people to buy into the testing, not after they're born, but in the prenatal stage. The disease doesn't have to continue to be promulgated. And if there's this kind of failure to buy in, and if it's, I mean, I don't know for sure whether there are religious folks that are pushing against this kind of testing, but from a physician standpoint, if we don't do the things that we can do to eliminate the diseases that can be eliminated, then we're not doing our job. And it seems to me we have a societal obligation to make these genetic moves when they don't have any particular downside for the patient. You know, the freedom to choose is certainly something to respect. But on the other hand, if it can be identified in a prenatal stage and that birth terminated, or more importantly, if someone can then be identified as being a carrier and then, or not a carrier, but someone who has the disease and then not being allowed to procreate, then we can eliminate this disease.
I'm sorry, that means you just killed my grandson. That's hard to solve.
No, just have him not have children. If he has the disease, don't have him pass it on. Yes, ma'am.
Hi, I'm a nurse, and I found it interesting, your feedback. One of the issues that I think that I was a little surprised about was I didn't see the issue of a genetic discrimination as a factor that came in. I think we dealt with perhaps the minister and healthcare workers. I think, and you stated that you had not, that was your next step to look at patients. But why do you think that genetic discrimination didn't come about? I mean, across a lot of this, it's been my feeling that it should at least have come out in some way.
If I had to make a guess, which would only be a guess, so these were 1.5 to 2 hour focus group conversations. We had that general set of questions that we tried to open up, and that wasn't an immediate concern for the people with whom we spoke. There were so many topics that were covered in each of these that perhaps in further focus groups that would arise, but for these, they were more concerned with their personal experiences, with their patients or their parishioners' experiences, more than on a broad policy level or if I were a patient. It might. We'll find out when we talk to them. If we've learned one thing, it's that we have no idea what's going to show up in these focus groups. That's what's made this so entertaining and so enlightening.
I think we have time for one more question at the back before we move to our second two presenters in this section.
I agree with this man right here in a sense, in that now that we have all of these technologies and genetic tests, that it is our obligation to at least offer them to patients. The question then is what do we do if a patient chooses not to be tested? It's with increased focus on patient autonomy, the patient can choose to have a test or not, but I do feel it is our responsibility to at least offer the test and make sure that people know about them. I do not think there should be any coercion to embark on a series of tests. I think there's a misconception here that with any genetic test, especially for prenatal tests, that if you go down the road of getting a prenatal genetic test, that you're out on a kind of search and destroy mission. But for many people, choosing to have these genetic tests just helps them to prepare for different types of outcomes. And so I'm interested when you mentioned that many of the clergy were not in support of the test. Were they not in support of giving the information about the test or not urging people to have the test? From a medical standpoint, I feel that it's our obligation to at least offer them and to give people the information that we have.
The concern, again, for most of the clergy with whom we spoke was that prenatal testing would lead to abortion. That was the problem. They were not opposed to gaining information if the patients and families were themselves opposed to abortion, but they saw that was going to be that was an immediate connection that was made in almost every focus group, including those that we had with clinicians talking about their patients and the associations their patients made. So I don't know if that answers your question, but.
And to add to that from, I guess, a personal note, I have a husband who's a minister, and as I have these dialogues with him, especially about prenatal screening, and you have to realize he's a Southern Baptist minister in Mississippi, so we're coming from a Southern perspective. His question he always poses is, okay, you have the screening, so what? Mm-hmm. What do you do with this information that you have it now? And so I think the gentleman who talks about, okay, now we can start to eliminate some of these disorders, makes a valid point, but I think we always have to, we can't disconnect it from the spiritual or religious beliefs that individuals have and the potential ways that it may play out. And so that's what he always encourages, looking at the pros and the cons, the what-ifs, and playing out the what-ifs. Can you live with the different choices, or how would you respond to the different choices that are available to you? And I would imagine genetic counselors go to something very similar to that. But that, you know, I agree. We provide the information. We provide, in some cases, the choice of the screening, but ultimately the what-if comes into play as it relates to the decisions that those we serve will make.
Okay, thank you very much. Okay, I'll now invite Tina Harris to come up. I just flipped that.
Yeah. Sure I did. It takes a second.
And we'll follow the same format. We'll hit with Tina Harris and then Anita Kinney, and then we'll follow that with question and answer period.
Okay, the study that I'm going to be presenting on today essentially looks at the influence that religious frameworks have on how the lay public makes sense of or attempts to understand the intersection between genetics, health, and disease. From my personal perspective, one area of research that, or one, I guess, variable, I don't like to use that word because I'm qualitative, but one aspect of an individual's identity that I think is really critical to understanding how people make sense of their lived experiences, and in this case health, is to look at their cultural identities. They play a critical role in shaping how we understand ourselves and how we define ourselves, and even within the context of genetic health information, our cultural identities play a critical role in impacting how we are going to understand and make sense of that information. They influence how the lay public, in particular, processes communication messages regarding health and genetics. I do have to make one brief disclaimer. I'm not a geneticist, so I'm here to learn from you all as well. Okay, so as far as the past research is concerned, much of the research that deals with health communication in general has demonstrated that the African American community demonstrates a high level of religion or religiosity and spirituality. And I found that to be true in other research that I've conducted, but in this particular study I wanted to explore it on a more in-depth level as it relates to genes and health. This was part of a grant that was funded by the CDC, and I wanted to find out if that held up to be true for this particular community. I think in general when we think about health, everybody has their health. Hopefully they're in good health, but when it comes to health messages and how they're framed, I think it's important to consider taking a culturally sensitive approach. One approach for one community might be more effective. However, if you use that same approach with another community, it might be a little bit problematic. So we have to continue to conduct research that helps us to understand how can we address these cultural differences and then use the findings to develop a culturally sensitive approach to research. Bless you. So the research question that excuse me, was driving this particular data or this analysis is, do racialized and cultural standpoints contribute to understandings lay individuals have about the relationship between genes and health? Okay, so the method for this particular study was qualitative in nature, and it involved, it was a part of a larger study, and I tried to recall the exact number of participants beyond the study, but I couldn't remember it. But once I get home, if anybody has questions, I can email that to you. But it was a part of a larger study that really explored genetics on a deeper level. The question that I presented, which I'll discuss in a moment, dealt with religious identity and religious behaviors, and so the study for the most part was not dedicated to that, so I don't have as much data to analyze in comparison to other content. But so we wanted to understand the connection that individuals were making between genes and health and their religion. The individuals who participated were low economic status African Americans and European Americans, and so they had an income of less than $35,000. They lived in rural and urban areas of the South, and a total of 50 in-depth interviews were conducted. So 40 participants were recruited from a research firm called Orc Macro, based in Atlanta. And individuals were recruited at locations where low-income individuals were present, and they were invited to interview through a one-on-one approach. So places such as the Salvation Army and low-income apartment complexes were our site for recruitment. In order to increase our number of participants, we interviewed 10 maybe I'll just put that over here. Okay. 10 additional participants were recruited, and they were younger and were recruited at places such as a barbershop and beauty shops. They received a $75 honorarium for their 1-hour interview, and over 90% agreed to participate. Okay, so the unit of analysis that was used for this study involved talk turns or responses that participants had to the question about their religious beliefs and behaviors. I isolated those responses just to have a good sense of, what kind of religious behaviors do you engage in, and in the actual question that was asked, we used examples such as, prayer and fasting, and just left it at that if the person had a general sense of what we were looking for. The question was also then, the question that was asked really wanted the participants to provide descriptions of the religious beliefs and behaviors that they identified as being important to them if they existed at all. And we wanted to really understand exactly how important they perceived it to be in terms of their own health and understanding of health situations in general. So from there, after I isolated the responses to the question about their religious identity, we also looked at the responses that participants had to questions about 3 different diseases: heart disease, lung cancer, and diabetes. And so the question of interest was, who is at greater risk for disease? Gene, who has the gene for X disease, or Doug, who does not? So participants were also probed to discuss whether or not they believed healthy or unhealthy behaviors affect their risk level. So the results yielded 318 talk turns, and 98 of those talk turns had demonstrated a clear discussion of religious behavior. So that was the first unit of analysis. And there were a total of 48 participants who were actually included in this particular study. 27 I was going to say they still are African American. 21 are European American, 26 are female, and that broke down into 13 white and 13 blacks, and then 22 males, 8 whites, and 14 blacks. And there were 2 participants who either chose other or didn't provide their race, so we couldn't include them in the data. And so from those talk turns, 75 of those talk turns, or 70%, were a confirmation by participants that they ascribed to a religious framework. We didn't ask them about denomination, but they answered in the affirmative. And of those talk turns, they represented 21 women and 12 men. And 50% in terms of race, 55% are African American, and that accounted for 100% of the females and 30% of the males. And in terms of European Americans, 56% were accounted for, and that was 61% of the females and then 50% of the males. So there are 5 specific religious frameworks that seem to be adopted by the participants. And so what I'll do is I'll provide a brief description of the framework and then an explanation that the participants offered of their understanding of genetics and disease. So for 2 participants in particular, they believe that health is predetermined. That was white male 157 and black female 64. So for individuals who responded in this manner, they have a belief that one's health status is predetermined by God. These participants see the role of God in their lives as having one function, whereas prayer as a religious behavior feels a separate and undefined purpose. And so they believe that they have a belief that God does exist, but my health is what it is. They didn't say upon birth, but I'm assuming that that's what they're inferring there. So when they were asked when they were presented with the question about Jean and Doug and who's at risk for disease, one participant responded that with regard to genes, it's certain, or you are definitely going to have that disease regardless of any other factors. So for the black female, she said she believed that having the gene for a heart disease or diabetes is a certainty that a person will indeed eventually have that disease. So she believed that pretty much across the board. For the white male, however, he had a little bit of uncertainty here. So he says just because someone, it's in their genes, hereditary or whatever, doesn't necessarily mean they're going to have it. Really, I think it would be kind of equal on both parts, really, because if it's in the genes, just because it's in the genes of one person and not in the genes of the other one, still don't increase his chances a little bit more of getting it, Actually, the disease developing in him. And so he kind of wavers a little bit back and forth as far as to the extent to which he believes genes are predetermined, or your health is predetermined. Then there were individuals who believe that religious behaviors have a preventative function. And so the definition or description that we have here is that this is the espousal of a proactive religious behavior has the potential to significantly reduce or the risk or heal one from an illness or disease. And so the individuals that responded here are African American, 2 black males, and 1 black female. Okay, so for black male 11, I just wanted to use his statement here. He believes that prayer is the solution to the problem of disease and that God won't allow you to be stressful for longer than the few seconds you realize something wasn't right, and then you think, oh, I got to still trust in him. Then stress is gone. So he's believing that your faith needs to be active. So when it comes to genes and health, all 3 had a clear belief that having a gene for heart disease, lung cancer, and diabetes, coupled with negative health behaviors, significantly increases one's likelihood for actually having the disease. And so based on how they responded to the question, they were indicating that if a person engaged in positive health behaviors, that they would reduce their risk. So they let me go back to that slide real quick. So they believe that their health is at risk, but it's reduced if they change their health behaviors. Okay, so preventative health behaviors were also, noted by 3 participants, and this means that there's an assumption that engagement in certain religious behaviors along with preventative health behaviors will prevent the onset of disease. So they specifically talk about behaviors such as proper eating, regular doctor's visits, and exercise as a means for reducing one's risk in addition to their religious beliefs. So 2 white females offered the following responses. I believe that all things are possible through Jesus Christ, and I believe that in the Bible, I'm a Christian, and I definitely believe what Jesus God said, that my stripes that by my stripes you are healed. Prayer helped. I mean, it gave him, and this person was making a reference to a family member or friend who had a health disease. Had a disease or condition. Prayer helped. I mean, it gave him, 20 years? No, not that long, about 15 years, because he had churches praying for him. But I do believe in healing. So when we ask the question about the relationship with genes and health, these individuals, or this particular woman here, believe that genes and behaviors do interact. There are two women here who espouse this belief. So according to, I think this is White Female 102, she states, because number one, if they know that they're diabetic and they continue to do what the doctor tells them not to do, it's kind of like playing Russian roulette. They're taking great big risks, don't eat any sugar, and now there's so many sugar-free things that they can have, that's just as good. And so she's saying that that there is a relationship between your genes and behavior, which goes back to the previous observation or a finding that they also believe that religion plays a critical role in health. The fourth religious framework is that healing is temporal. Much like preventative health behaviors, which we just discussed, there is recognition by participants of the critical role of prayer in one's health. The belief is that religious behaviors such as prayer do have the potential to create temporary change in a person's health status, suggesting that the disease remains dormant, even though the signs or symptoms may not be visible. And I just have to also share this. I also was getting confused when I was analyzing the data because participants seemed to adopt one way of thinking and then they would adopt another, and I thought, after that, now I don't even know what I think anymore, but it was enlightening nonetheless. But two black males and provide an explanation or an indication of their beliefs. Well, prayer helps, but if you get heart disease, I don't think nothing can help that. Yeah, prayer makes a difference. When asked if a friend can be healed from diabetes, black male 59 replies, no. His friend can live his life out comfortable, by exercising, and healing would put the disease off temporarily, not forever. So when asked, or when we looked at the data or the responses to the question about genes, both males express a belief that if the gene exists, that a person will in fact have the disease. As for black male 59, he responded to the question about heart disease, lung cancer, and diabetes with the same response. Gene means disease. So he didn't really elaborate too much, but it's clear there what he believes to be true. And finally, the fifth framework was that level of faith determines healing. And this essentially means that there's a clear belief that engagement in religious behaviors such as prayer do facilitate healing, which is significantly dependent upon a person's level of faith or the extent to which they believe their religious behaviors will in fact result in a change in their health status. And so there were three individuals who espoused this belief, a black male, and then a white male, and a white female. Okay, so according to black male number 13, as long as you believe in God, and keep praying, God work in strange ways. Yes, only if they believe, They have to really believe and trying to purify themselves, because that's what basically prayer is about. Really praying from your inside, your inner self, because it's so much. And I was just finding out all types and sorts of things because I pray a little on the health things myself, but I don't abide by it. I don't live by it. You know what I'm saying? Okay, so as it relates to genes, these individuals had a general consensus that gene means disease. Both participants in particular explained that if the gene is present, a person will certainly have that disease. And if they engage in certain behaviors, such as prayer and proper diet, they can reduce the risk but will still get it regardless. And finally, so in our paper we have a couple of points here that we think are really worth noting. First is that racial ethnic differences were present in terms of ways of thinking about health. So as I showed on one of the earlier slides, there were a significant number of African Americans who espoused a religious belief, not saying that That was not the case for European Americans, but in this particular population, African Americans espoused it, which is consistent with the research. So we have to really consider that ways of thinking about health and quite possibly life experiences in general are directly impacted by their religious beliefs or frameworks. Okay, a second observation is that positive health behaviors essentially equate to staving off disease. Thus, there is a dichotomous frame of thinking. So individuals adopting this way of thinking appear to adopt ideologies that are mutually exclusive, which can be problematic for health communication scholars and policymakers attempting to educate the lay public about various health issues and reduce race and ethnic disparities in healthcare, which, we discussed it in the conclusion in the paper. And the third observation or conclusion is that many of the participants believe, regardless of their religious beliefs, that gene equals disease. So they believe that the presence of a gene for heart disease, lung cancer, or diabetes will definitely result in a person having the disease. And for some people, they believe that health behaviors can function to alleviate the severity of a disease, but it's not believed to affect the onset of the disease. So for many of them, the disease is still present in their body, which is reflective of an obvious need to properly educate the lay public about genes and their role in determining a individual's health. So without this information, individuals are at risk for misinformation and making decisions that may adversely affect their health. So in conclusion, strategic efforts must be made to treat the whole of a person or patient, and that includes the way in which they process health information. In terms of the lay public, they constitute a complex and amazing body of individuals devising unique and critical means for making sense of emerging trends in human genetic research. Therefore, we anticipate that our current and future research can be used to reduce race and ethnic disparities in health, as well as the knowledge gap regarding advancements in human genetics research. Thank you.
We're going to hold off on questions for Dr. Harris until we hear from Dr. Kinney, and then we'll take all the questions at the same time, similar to the previous two presenters. So please make a note of your questions and comments arising from Dr. Harris's talk. Are you on Mac as well?
I think Joe has this one. What do I use to get this one to go?
I'll get it for you. I'll try. Where's Joe? Is this it, Joe? No.
No. Kinney.
Oh, this is it. Yeah, sorry, Joe.
And then
okay.
press.
I think you can advance with this. Yes.
Okay.
Okay.
Good afternoon. I have a disclaimer to make. I am not a religious expert. My background is in epidemiology, and I study psychosocial and behavioral aspects related to a variety of health outcomes, and my focus is primarily on cancer-related outcomes, decision-making, and risk communication. So I'm going to provide some context and the objectives of our study. I'm going to briefly review methods, draw some conclusions, and make recommendations for future research. Approximately 184,000 breast cancers and 22,000 ovarian cancers will be diagnosed in the United States this year. Of these diagnoses, approximately 5 to 10% will be attributable to known predisposing genetic factors. Two major genes associated with hereditary susceptibility to breast and ovarian cancer, breast cancer susceptibility gene 1 and breast cancer susceptibility gene 2, BRCA1 and 2, which I'll refer to as BRCA or BRCA1 during this talk. The prevalence of BRCA mutations in women with breast cancer is not markedly different in African Americans and whites of non-Ashkenazi Jewish ancestry. But compared to whites, African American men and women have a poorer survival rate for nearly every cancer site, including breast, ovarian, colorectal cancer, and prostate cancer. Consensus-approved clinical guidelines recommend that individuals who have greater than a 5 to 10% prior probability of carrying a BRCA mutation be referred to genetic counseling and offered genetic testing by a trained genetic counselor. And one of the potential benefits of genetic counseling is to help clinicians and patients make more informed decisions about preventive strategies. In light of these facts, we conducted a cross-sectional research to assess the effects of religiosity and spirituality among psychological distress in a high-risk cohort of African Americans, men and women. And these men and women had a greater than 25% prior probability of carrying a deleterious hereditary mutation. It is important to note that there is no clear distinction between religiosity and spirituality, and that operational definitions of these two constructs are often vague and inconsistently defined. Some have conceptualized these two constructs as distinct from each other, while others have described the constructs as interconnected. A full discussion of these conceptualizations is beyond the scope of this presentation and paper, and most of you will be familiar with the general concepts. Generally, religiosity or religiousness may be viewed as organizational or non-organizational aspects of faith, including religious affiliation, organizational religiosity as a measure of the social dimensions of religion, such as participation in a church or place of worship, or participation within a church or place of worship group. Non-organizational aspects of religiosity, such as private activities, such as praying or reading religious scriptures. And then subjective religiosity, individuals' perceptions of how religious or spiritual they are. And then religious coping, the role that religion plays in problem solving and coping with life stresses. Spirituality commonly pertains to experiences relating to God or a higher power, as well as a personal quest for finding meaning and purpose in life, which may or may not arise from religious beliefs and practices. It may consist of external manifestations of individual beliefs and one's inner spiritual state. When referring to religiosity and spirituality factors here, the label RS will be used. So now I'm going to just provide some context with regard to hereditary cancer susceptibility. For each person diagnosed with hereditary breast and ovarian cancer, there are often family members at very high risk of getting cancer and of inheriting a cancer predisposing mutation. These families often have more than one family member with cancer diagnosis, and there may be a family history of multiple cancer-related deaths, often at young ages. According to stress and coping theory, identifying a threat to one's life leads to stress and distress. Individuals who are informed of their increased risk and subsequently perceive a high risk, both personally and for their family, of being diagnosed with a life-threatening illness may potentially carry a substantial burden of distress and feel distress. This threat may extend to concern about an actual transmission of a deleterious gene mutation to their offspring. BRCA1 and 2 mutations are transmitted via autosomal dominant modes of transmission, and males and females may carry the gene and transmit the mutation to their offspring. So there's a 50% risk of carrying a deleterious mutation if you have a parent that's a carrier. Not all carriers get cancer, so the probabilities may range from 6 to 10% for prostate cancer in men to as high as 85% for breast cancer in women. Males may also get breast cancer, but the risk for getting cancer is lower than female carriers. It is not yet clear. Before I move on, I just want to make some points about religiosity in the context of the U.S. population. And I'm going to briefly review this. 95% of Americans believe in God, and 95% of the population 84% of Americans are affiliated with a religious faith, and approximately 87% of Americans identify religion as being at least very important or moderately important in their lives. This is not just in Salt Lake City. So religion is a prominent theme in the lives of Americans throughout the nation. Thank you, Nancy. So religiosity has been associated both with mental and physical health, disease and treatment recovery, and mortality. It has been shown to have positive effects on the immune system. Many studies fail to control for relevant variables and or lack a meaningful specification of theoretical models. The vast majority of studies use crude measures, as you've heard earlier, and crude measures may oversimplify the construct of religion and spirituality. And there are limited data on the role of religiosity and spirituality and coping in the setting of genetic risk, particularly risk for hereditary cancer, adult-onset cancers. So religious involvement is central to the lives of African Americans. Religiosity and spirituality may help reduce psychological distress, and this has been shown in African Americans. Churches provide linkages to community health resources and provide social and psychological support. Religiosity and spirituality promote an adaptive and supportive role in enhancing mental health and physical well-being in African Americans. And the associations with religiosity and spirituality and health tend to be stronger for blacks or African Americans versus whites, especially with regard to mental health. And there are negative aspects of religiosity, and these are understudied. So religiosity and spirituality are often used as coping strategies. A doctoral student of mine conducted qualitative research among BRCA1 and actually 2 carriers, and her dissertation provides stories of women of how religiosity and spirituality related to their being a member of a family with a deleterious BRCA mutation. And what Susan Tinley, who's at Creighton University in Nebraska, found was that their religiosity and spirituality was intensified as a result of finding out that they carried a deleterious mutation as well as being part of a family, and that their religiosity and spirituality helped them find meaning and help them cope with this genetic information. They identified religious and spiritual beliefs as providing a source of support, helping them make decisions. Some of them needed to make decisions whether they wanted to have both of their breasts removed to prevent breast cancer from occurring, having their ovaries removed, choosing between prophylactic or preventive surgical procedures versus screening or opting to do nothing. So they often turned to their religious and spiritual beliefs and practices to help them with these complex decisions. And they expressed an openness and eagerness for spiritual care regarding genetic health. Religiosity and spirituality factors have been associated with cancer prevention services, both positive and negative aspects, and the results from those studies are very interesting. Religiosity and spirituality have been shown to predict genetic testing uptake in some studies and not in others. And in my own research, as well as Dr. Tinley's research and others, participants often identify a need for pastoral counseling to help them cope with fear, loss, and grief, and provide advice or referral to seek medical care and to craft health messages to help them get medical care. And we know that religiosity and spirituality are differentially associated with genetic uptake depending on what measures are employed. So in our study, we used the transactional model of stress and coping, which details a 3-part process: cognitive appraisal, emotional responses, and coping efforts of dealing with stressful life circumstances. According to the model, an individual's initial response to a stressor is a function of 2 sequentially linked cognitive processes: primary appraisal and secondary appraisal. In the context of this study, we conceptualized the stressor as membership in a family with a BRCA1 mutation and primary appraisal as one's perception of susceptibility to the threat of carrying a mutation. Once the individual makes a cognitive interpretation of the threat posed by the stressor, they conduct a secondary appraisal to decide whether or not they have the resources to cope effectively with the stressor, which we call coping self-efficacy. These appraisals then prompt an individual to cope with his or her concerns about the stressor. And coping refers to the individual's cognitive and behavioral efforts to manage their stress. The conceptual model specifies 3 general categories of coping responses: directly changing the problem or situation from which the stress ensues, altering the meaning of the situation or reinterpreting the problem, and third, managing the emotional distress. Our experience suggests that demographic and psychosocial variables may modulate the stressor and the coping response. In addition, for some, religiosity and spirituality play a crucial role throughout the coping process, influencing the meaning that people attribute to stressors and their appraisal of the resources and use of coping strategies that they have available. These factors and processes may influence psychological reactions to being a member of a family with a deleterious BRCA mutation. So the objectives of our study were to characterize select aspects of religiosity and spirituality in African American men and women who are at increased risk of carrying a BRCA mutation. For exploratory purposes, we evaluated the relationships between religiosity and spirituality attitudes and practices and both general and cancer-specific psychological distress. So I'm going to provide a brief overview of the PARENT study, which was funded by the National Institute for Human Genome Research. And this was a prospective pre-test, post-test design where members of a large African American kindred with a known BRCA1 mutation were offered clinical genetic counseling and testing. About 41% of the members of this kindred had participated in prior genetic research. This was a genetic epidemiologic study that led to the cloning and eventual clinical availability of genetic testing for this syndrome. Many of the kindred members did not know each other. They were related by a common ancestor. We used a 5-generation pedigree to recruit kindred members. The vast majority of kindred members lived in southern Louisiana, not Utah. One member, however, did reside in Utah, but not in Salt Lake City. And this was a rural area in Louisiana. Kindred members' ancestors were Creole, and many of the kindred members still consider themselves to be Creole. So in some families, both Creole and English was spoken. The study sample included females and males without a personal history of cancer, and they were 18 years of age or older. We conducted computer-assisted telephone interviews or computer-assisted personal interviews. The analysis that we conducted for the purposes of this presentation and paper was cross-sectional in nature. These data were obtained from the baseline interviews of participants prior to formal genetic education, counseling, and testing for those who chose to be tested. All of the participants were informed that a BRCA1 mutation had been found in their family and that they were at risk for carrying the mutation. So the age of our participants, mean age was 40. About half were female. 39% had a household income of less than $30,000 a year. 40% had a high school education or less, and most were Catholic. We used the Center for Epidemiologic Studies depression scale, and 27% of our participants reported clinically significant depressive symptoms. 33% of females had depressive symptoms indicating a referral to for more formal psychological counseling. We also assessed cancer worry with a 3-item cancer worry scale, and cancer worry was relatively high in this population. We assessed likelihood or perceived threat of carrying a deleterious mutation. We asked participants how likely is it that you have an altered gene, and 52% believed that it was likely or very likely that their relatives would develop cancer, and 82% believed that they had a moderate chance to very likely probability that they would be carrying a deleterious mutation. We asked about perceived controllability. The question was, no matter what I do, there is a good chance that I'll develop cancer. 34% agreed and 37% were neutral. 57% believed that they would cope well with their genetic test results should they choose to be tested. We assessed functional aspects of religiosity as well as structural aspects such as organizational aspects. 88% of our sample attended a place of worship. 60% attended a place of worship at least weekly. Many of the participants attended church more than once a week. And 56% reported that they belonged to a group within their church or place of worship. We also asked how frequently our participants prayed. 80% reported that they prayed most of the time or every day. 80% believed that their religious faith was very important to them, and 19% reported that it was somewhat important. We also asked how important their religious beliefs were in helping them cope with stressful situations. And you can see here 18% said that it was important and 64% said very important. Then we also assessed religious problem solving, which can serve important functions in helping people understand and cope with stressful events by providing guidance in the process of selecting solutions to problems, providing emotional support, influencing how one makes sense of problems, and providing a source of hope. We used an 18-item scale that assesses 2 dimensions of religious problem solving, locus of responsibility, and level of activity. 3 subscales comprise this scale, and I'm going to briefly mention the 3 religious problem solving strategies. Self-directing strategy relies on personal rather than religious resources to solve problems. The deferring style is when religious expressions are tied to traditional structures and dogma and the belief that God will respond to personal needs, more of a passive coping style. And then there's the collaborative coping, which relies less on God to meet personal needs and more on practices which facilitate and maintain a personal relationship with God, more of an active coping style. The most prominent coping style in this group was the collaborative coping style, and there was an error in your abstract. Standard deviations were off by a decimal point, which is pretty significant in terms of statistics. So just make note of that. Just briefly observed associations. We found that female gender, marital status, and household income were associated with depressive symptoms. There was a trend suggesting that more frequent church attendance was associated with the presence of depressive symptoms. This did not reach statistical significance, but was marginally significant. And females reported higher levels of cancer worry. We also looked at correlations, and we found that frequency of prayer was modestly correlated with strength of family history, so that those who had a stronger history tended to pray more. All religious problem-solving styles were moderately correlated with prayer, where higher levels of religious coping were significantly correlated with frequency of prayer. And religious practices and beliefs were correlated with each other, such as church attendance, prayer, and importance of religious problem-solving. So in conclusion, religious and spirituality practices were prevalent among our study population. Many of the participants revealed strong religious and spirituality beliefs. Depressive symptoms were high. They were quite prevalent. The temporality of the observed trend in church attendance and depression is not clear. The collaborative coping style was the most prevalent problem-solving style. And RS, as measured, factors were not significantly associated with distress in this sample. Religious practices may be an important source of coping and may be context-specific. And knowledge of risk factors for distress may inform religiosity and spirituality interventions, and more needs to be learned about stress buffering effects. In terms of limitations, this was a secondary analysis. The religious factors that we used were included more as covariates, so assessing religiosity and its effects on distress was not our primary area of interest. The study was cross-sectional in nature. There are cautions about generalizability, as this was a convenience sample.